Welcome, everyone. I'm Dick Deming. I'm Medical Director of the MercyOne Cancer Center and founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And our guest tonight is Dr. Ashley Bauer.
Hi.
Dr. Bauer is an ear, nose, and throat doctor, or also known as an otolaryngologist, and she is with the MercyOne ENT clinic. So welcome.
Oh, thanks for having me.
So where are you from originally, Ashley?
So I'm originally from Scottsbluff, Nebraska, which is clear western Nebraska, closer to the Wyoming border than it is Iowa.
And how big of a high school?
Oh,
How many in your class?
I think 100 or so.
Okay.
Yeah. I mean, it wasn't totally small, but we lived out on the farm and kind of commuted in. And so
did you farm or ranch? Or
farm. Yeah, my dad farmed.
Okay.
Yep. And so I have 3 sisters, and we tried to help as much as we could on the farm.
What was your claim to fame in high school?
Oh, mine? I did show choir. I was more of an artsy person. I tried sports, but I was never that athletic. So I think it was more show choir and doing very good at studies. I tried really hard in school.
Okay.
So
well, good. And then you went to undergrad at University of Nebraska in Omaha.
Yes, correct.
And did you know you wanted to be a physician when you started college?
I actually started in a computer programming major there. But in the back of my head, I thought that would be super cool. Our family, I would have been the first physician in my family. And I always thought that would be something to work forward to. I like to be able to give enough information to people and hopefully have that skill. And so I think it was in the back of my mind, but it wasn't at for sure.
Okay. And then somewhere along the line, second or third year in college, you committed to pre-med?
I did. So kind of the backstory is that my sister, who's just a year older than me, was diagnosed with thyroid cancer. And we were scared, our family. She was only 20 at the time, and went to the University of Nebraska and met with a really, really great head and neck surgeon, Dr. Bill Lydiot, and he took her thyroid out. And yes, it was thyroid cancer. And my mom, I remember I went, for some reason, I was 19. I went to one of those appointments with her postoperative appointment. And my mom was like, you feel Ashley's neck and you see if and he was like, well, she does have she has a thyroid nodule. And so he took my thyroid out. And luckily mine weren't cancer. They were suspicious for, which is something we deal with in thyroid cancer a lot, not always knowing until you remove the thyroid. And after surgery, he made such a big impact on our family that I asked if I could shadow him in clinic. I went to the operating room as a undergrad, and I scrubbed in on a thyroidectomy and held the retractors. I still remember it.
Wow.
And after that, I was like, I want to do this. He wrote my letter to get into medical school. In medical school, I focused on otolaryngology because I had this background history.
In medical school
at the University of Nebraska.
Right.
So I was able to work with him as a medical student.
Wow.
And then he helped advise me on where to go to residency. And luckily I was able to get into a very competitive residency. And then that's where I went to the University of Michigan, which has a really, really, really strong otolaryngology head and neck surgery department. And then I did 5 years in Ann Arbor.
And so the residency for ENT is 5 years.
5 years.
And then you went on and did a fellowship after that.
And then after 5 years of working really hard in residency, I actually migrated more towards sinonasal surgery and sinonasal cancers. And so I did a fellowship at Vanderbilt University, Medical University in Nashville in anterior skull base and rhinology surgery.
Okay. Yeah. And then you practiced in Omaha for a bit. You were at Creighton.
I was at Creighton. I came back to the Midwest to be closer to family. My family has now migrated to Des Moines. My sister, 2 of my sisters, 3 of my nephews, and my parents. And so I thought, I'll go closer. I'll be closer to them. And I'm familiar with Omaha. I've been there for many years. And so I was at Creighton, but it wasn't close enough. So I eventually moved to Des Moines.
And who's taking care of the farm?
So we actually do still have some farmland in Scottsbluff, and we have a farmer that's helping us take care of it.
Good. Yeah. Good. Well, we are so fortunate to have you. And Many of you may know that at cancer centers, we do what's called a multidisciplinary cancer clinic, where we discuss all the cases. And Ashley has been a key member of that group. So it's nice to have you here
It's
and
good to be here.
be in person with you. So our topic tonight is head and neck cancer. How would you define head and neck cancer? Maybe give us a feel for anatomically what various cancers fall into the umbrella of head and neck cancer.
That's a really good starting point because head and neck cancer involves a lot of different systems. So when we think about part of head and neck cancer is actually the skin. The skin is the biggest organ in the body, and we do different things based on location, but skin cancer is actually a big part of head and neck cancer because if it is really aggressive, it goes into key structures of the face. If it metastasizes, it'll go into the lymph nodes of the neck, and it requires a multidisciplinary team approach as well. So skin is one of them. Then we have saliva glands. Saliva glands can cause cancer. The parotid glands in front of the ear, the minor salivary glands in the mouth and the throat, the submandibular glands right here. That's another type of cancer that we see sometimes. We see a lot of benign tumors there, non-cancerous tumors there as well. When you think about nasal cancers and sinus cancers, those are rare, but they are things that we see, and they can generally be a little bit of asymptomatic players, and they can be different types. So that's another site where it can be on the inside of the nose and the sinuses. And then we've got what we typically think of as throat cancer, which a lot of people are thinking head and neck cancer as throat cancer, but even throat cancer has many different players. We've got cancers of the inside of the mouth and the tongue. We've got cancers of the back of the throat and behind the tongue, called the oropharynx. Then we've got larynx cancers and cancers near the esophagus. Those are all different types of cancers that require different types of multidisciplinary treatment. And based on, we call it subsite, the subsite of the cancer, usually they're treated very differently based on how they act.
Right. And in general, the three different ways of treating cancer would be surgery, radiation, and chemotherapy.
Yes.
And more, many of the cancers require more than one of those different treatments. And
correct.
And a lot of coordination to decide, well, what goes first?
What goes first?
Yeah. Do you do just one of them, or do you do all three? And how do you decide which order?
And our goal is not only to cure, like first and foremost, we want to cure this cancer, but number two is to do the least amount of modalities so that we can have the least amount of long-term side effects.
Right.
And that's what we're still learning, especially with HPV-related cancers. How much can we do to still cure this person, but have limited side effects of treatment?
And preserve function. As much as possible. Obviously, speech and swallowing
and breathing.
Yes.
And voice. And exactly, that's, I think, a very specific to this area is that there's a lot of function that we want people to have after treatment because we want them to have a long and healthy life. But it's such a big vital part to quality of life is speech, swallowing, and voice.
What are some of the risk factors that put some individuals at higher risk for developing head and neck cancers?
So we know that smoking consistently over a long period of time, smoking tobacco is a risk factor. The other thing that I don't know that people know is drinking alcohol consistently and heavily is also a risk factor independently of smoking. However, if we combine smoking and alcohol use, your risk goes exponentially bigger. So it's not 1 + 1 = 2. It's 2 times. I didn't do that very right, but it's not like 2 + 2 = 4.
It's not additive.
It's not additive. Yeah. It's a multiplier. And so that's the highest risk factors. But there's also bad luck, and there's also viral cancers that usually are not as related to smoking and drinking. However, that can play a part.
Yes. So I'm going to be 70, quite a bit older than you. Head and neck cancer has changed dramatically in my professional career. I've been a doctor for 43 years. And typically, if we're talking about oropharynx.
Mhm.
You define that as back where the tonsils live and the way back of
The
the base of the
uvula, the
tongue.
dangly part, the
Yeah.
back of the throat. Yeah.
So when I started my career, people with that type of cancer were almost had the two risk factors you mentioned initially, lots of smoking and lots of alcohol.
Mhm.
And that has changed dramatically. And now the most common cause of oropharynx cancer is a virus.
It's a virus. Yep.
HPV virus. What is the HPV virus? And tell us a little bit about HPV virus and its relationship to oropharynx cancer in the back of the throat.
So the HPV virus is a virus that we all come into contact to and at some point probably have in our bodies. In women, it can be still throat cancer, but it also can be cervical cancer. And it's something that you may not have any symptoms from whatsoever. So it's a virus that lives in our cells that we may not know we have, but that can cause long-term consequences. Just like when women have cervical cancer screenings and they can tell with that whether you've cleared that virus or not, in the throat it's a little bit more difficult. And so some people can carry the virus in their throat, and over time that virus can cause mutations and changes in their DNA that can predispose them to cancer. It's a higher likelihood in men in throat cancer, and it's a younger decade than it is other types of cancers as far as throat cancers. So it's usually like 50s and 60s instead of 60s to 80s. So it is a little bit younger for the HPV type of throat cancer.
And in the United States this year, there actually will be more men with HPV oropharynx cancer than there will be women with cervix cancer.
That's interesting. Yeah.
And one of the things, we've got a screening test for cervix cancer.
Yeah.
We don't currently have a recognized screening test for oropharynx cancer.
Yeah, because usually when we take biopsies, we have to have tissue in order to stain for P16, which is a protein that is made from HPV, in order to determine whether that cancer has that virus in it. And that's how we can determine whether that cancer is caused by that virus. So it's not an easy swab test that we can do in the throat. And so it's a little bit harder to determine how we are screening these patients and who we need to be more concerned with.
So let's just stay on the HPV virus for a bit, because that has become such a one of the most common of the head and neck cancers. How does HPV mediated or HPV caused cancer of the oropharynx, how do patients present with that?
So most commonly, people present with a lymph node in their neck. They don't have any symptoms in their throat. They don't have pain. They don't have they really don't have problems swallowing a lot of times. They notice because they'll have a lump in their neck, because it tends to go to a lymph node in their neck pretty quickly, and the lymph nodes tend to get pretty big.
Right. So you can have a really tiny primary tumor that's causing no symptoms.
And it can go to the neck.
And then it grows in the neck much bigger than it grows in the primary setting.
Correct. Yep, correct. And so that's the most common way. And people come in, they say, I just have this lump, it hasn't gone down. It's been 3 weeks, it's getting a little bit bigger, and it just popped up overnight. It just wasn't there, and it's now there. It's just, they don't have a lot of symptoms except for they have a lump in their neck.
And what's the workup for determining that that's cancer? And
Yep. So usually it depends on if they end up in their primary care doctor's office. Usually their primary care doctor is like, yeah, that's not normal. They possibly might order a CT scan, or possibly they might call an ENT like our clinic and say, hey, can you guys get this person in really fast? We get them in for those reasons really quickly, and we try to get imaging for sure. I have a way to look at the back of their throat with something called a flexible laryngoscope, where I actually use a little camera that I go through the nose and I look at the back of their tongue, their larynx, the opening to where the esophagus is, and I can see whether there's anything concerning there. And then usually a biopsy. So if there's anything in the back of their throat or in their tonsil that's concerning, we biopsy that. We can biopsy through the neck with a fine needle aspirate in order to see if there's cancer there. So our goal is to get a diagnosis and then complete the workup to see where the cancer has spread to.
So one of the most common situations, as you mentioned, is a fine needle aspiration of the neck node that shows squamous cell carcinoma, that's P16 positive, the protein that is associated with HPV.
Correct. And then if I didn't see anything on my flexible laryngoscopy, which sometimes you don't, we might get a PET scan. And a PET scan gives us a way to evaluate for any really, we call it avidity, but cancer cells that are dividing quickly light up on a PET scan. So it helps us to be able to see even a very small tumor on a scan to know maybe where this originated from.
And occasionally we find an HPV cancer in a lymph node and we can't find a primary.
Correct. We don't know why this happens. We think maybe the immune system has taken care of the primary site. Like your body is warding off cancer every day. We have little cells that start to become a cancer. What we define as a cancer is a cell that's dividing and not listening to the body when it says you need to die, or you need to slough. If it's skin, you need to go away. And when it doesn't listen, it just keeps dividing. That's a cancer. And so our immune system is the biggest way we keep those cells in check. When it says, oh, this cell is damaged, it attacks it, gets rid of it. And so cancers are just cells that have been damaged, and their DNA, they're now uncontrolled, and the immune system has lost the fight. But our immune system is really important. And so maybe that cancer started, it spread pretty quickly to the lymph nodes. The lymph nodes drain the back of the throat. And then our immune system attacked it and got rid of that primary cancer. But we have a way of treating them where we have to try to target all the areas where it could have originated from so that we can try to prevent it from coming back.
And sticking with oropharynx cancer caused by HPV, we have 3 different ways of treating: surgery, radiation, and chemotherapy. How do you decide which patient gets one of the treatments versus perhaps all 3?
So in even my training, we started off with usually HPV and oropharynx cancers, which are in the back of the throat, are treated mainly with chemo and radiation. And we choose based on how well people do with those treatments and the limited side effects. If we cut out a lot of tissue, people can have bad outcomes. So in the back of the throat, they actually do better with chemo and radiation therapy. And then you leave surgery for what we call salvage. So if they continue to have problems or cancer, or the cancer comes back. The problem with head and neck cancer is when you cut something out, you have a big defect in function. And so actually one of the newer treatments for after surgery to restore function are called free flaps, where we use tissue from other parts of the body to rebuild the best we can areas of the throat, the tongue, the voice box, to try to help with function as much as we can. And that's the best we can do, but it's still not great. So if we can get rid of the cancer without cutting out a big important part of someone's body that doesn't reconstruct that well, that's the best outcome we can hope for.
So most of the time with the HPV mediated cancers in the tonsil region, base of tongue, chemoradiation, surgery is used to, you're involved with helping establish the diagnosis, the primary,
and salvage.
And then if they recur after chemotherapy or radiation.
However, the newer trials for HPV have been trying to limit, because it does so well. So HPV, as scary as it is, and for people that have done nothing wrong and no risk factors for it, it is very well treated, and people survive it at high rates. So upwards,
cure rate is much better for an
better.
HPV mediated cancer than the old-fashioned squamous cell caused by tobacco and alcohol.
Correct. So it has high cure rates, which is good news. So what we're trying to do with HPV oropharynx cancer is how can we take the treatment side effects down and still cure people? And so there have been trials in my training that have worked to do that. And so surgery, even as morbid as it is, with small cancers like the tonsil, can we do a tonsillectomy and take the lymph nodes out of the neck and not have to do any radiation and chemotherapy? And we know that people do pretty well with just a tonsillectomy. Now, if that cancer is involved into the deeper musculature of the neck, then probably a tonsillectomy might be too morbid. But there are certain small cancers that we're trying to do surgery first and only use radiation and chemo if there's any bad players on the pathology.
Right. And as you mentioned, one of the problems with surgery, if you have to remove too much tissue, you can adversely affect function. With chemo and radiation, although it's highly effective in getting rid of the cancer, there are late consequences, side effects I would say more late side effects than true complications that happen with the radiation. Swallowing issues, stiffness of the neck, hearing issues with the chemotherapy and the radiation, hoarseness, and swallowing difficulties that can happen.
Scarring of your esophagus, needing to be dilated and have your esophagus stretched, hoarseness, and having not a functional, we call it a functional larynx, where your voice box doesn't work and protect your lungs the way it should. Our vocal cords really have more of an important function than even voice, but to help us keep food and saliva from going into our lungs and causing aspiration. Dry mouth is common, and that's something patients struggle with once they've cured this disease and they're living long, healthy lives. Dry mouth it sucks.
Yeah, and the dry mouth is not just feeling cottony, but it affects taste, it affects swallowing, and it also, our saliva every second of the day helps reduce the bacteria that cause dental decay. So once you have a dry mouth, you end up with dental issues as well.
Correct. Yeah, correct.
So as you mentioned, we now know that HPV-induced oropharynx cancer has a much higher cure rate, and sometimes a limited surgery might actually have fewer side effects than chemotherapy and radiation.
Correct.
And in the world of radiation and chemotherapy, we're also looking at reducing the dose. That
correct.
Maybe you don't need as high a dose of radiation. And if we can reduce the dose, perhaps we can also reduce the late side effects.
Correct. But these things are done in stages because we have to enroll patients in trials and make sure that they have the same 5-year outcomes as the previous treatment. No one wants to be treated and have their cancer come back or take their life. They want to be cured. And so we have to do it in a safe way. And for that, it takes time. And so we're learning every year what we can do. Surgery for very small tumors without any significant lymph nodes, we're doing a lot of surgery for that. And we still take the lymph nodes out usually to prevent missing a little microscopic cancer. And then we look at the pathology after surgery. And if there's any negative results on the pathology that might indicate a more aggressive form, then sometimes you have to do more treatment.
Add some radiation in afterwards.
Yeah. But we don't want to do all three. And so we're trying to make sure we pick the right patients that we can give them the same result or the best result. Yeah.
And for those patients who do need chemotherapy and radiation therapy, the technique has changed so much over the last 40 years that I've been a physician. Initially, you treated with radiation just from the right and the left, and every part of the throat and the neck got the same high dose.
Yeah.
And now the newer techniques are to use techniques that preferentially give the high dose to the area where the cancer is and a much lower dose to the surrounding normal tissue.
And that's why when someone comes in, we try to find exactly where the cancer is from, because it helps give less radiation to the tissues we know the cancer didn't come from. And so sometimes when we go to surgery, and I go to surgery to biopsy or to take the tonsils out to try to find out where that cancer came from, it's not to cure them, but it's to help our radiation doctors to give directed radiation and limit side effects.
And it's not uncommon that you have a HPV cancer in the neck and the tonsil looks normal, and you take the tonsil out and you find a tiny bit of cancer that you couldn't see, even though you were looking for it. You thought it was there, but it's not until the pathologist slices the tonsil up and looks at it under the microscope that they find the primary site.
And that's why, you just got to take the whole tonsil out, which is no fun when you're an adult. But
what would you say is, let's go a little bit more anteriorly.
Okay.
Let's talk about cancers of the mouth and the part of the tongue you stick out of your mouth, right? That anterior tongue.
The anterior tongue. So these are types of cancers that actually are pretty aggressive, and they usually don't respond as well to chemo and radiation. And so surgery is huge. And when you do surgery in the mouth, you do usually have to reconstruct the defect that you make. And that's where free tissue transfers have been key and really huge in the development over the last 20 years for head and neck cancer. And so it's called a free flap or a free tissue transfer. So there's two surgeries. There's one surgery to remove the cancer and the lymph nodes, and there's another surgery to reconstruct the defect with tissue.
And sometimes bone.
Sometimes bone, if it involves either the jaw, the upper jaw, or the lower jaw. We can use our scapula. We can use the fibula. You can use the forearm. There's bones that we don't necessarily need, and there's tissue that you can live without. And we use it in places in our throat and our tongue and our cheek, or to block off our nose from our upper jaw, or to reconstruct our mandible in order to preserve function.
And the surgeons that do that, let's say, take a piece of the fibula, the smaller bone on the outside of the lower leg, and some tissue to reconstruct a mandible. Is it the ear, nose, and throat doctor that has the special training to actually take a piece of the leg, or do you have a plastic surgeon that's also involved in the surgery? How do you do it as a team?
That's a good question. So it's a fellowship in order to do the reconstructive part of the surgery. And you can either be a plastic surgeon that's done it's called a microvascular fellowship, because it's important to hook up the blood vessels in order to keep that tissue alive, or a head and neck or otolaryngology doctor who's doing a fellowship in head and neck and reconstructive surgery. And so we don't have any head and neck surgeons in town. We do send a lot of those patients to the University of Iowa or the University of Nebraska.
That do that.
That do that specific surgery.
Yeah.
Yes.
Yeah, it's kind of I'm going to have my ear, nose, and throat doctor remove a bone in my leg.
And that's why it's actually only a year, but it's a year where you're just focusing on not necessarily the resection, although there are some fellowships that just focus on doing a good resection, like Sloan Kettering. And MD Anderson has 2 years where it's one on resection and one on reconstruction. But it's really where you can get the tissue from and hooking it up in a way that survives, that tissue survives.
Let's talk a bit about larynx cancer. So larynx is another name for the voice box, and there's different tiny structures in there also where the cancer can be involved. So give us a little bit of a primer on larynx cancer, vocal cord cancer, and what causes it, and what are the various ways of treating cancer of the voice box? So
it's much more commonly caused by smoking, and still drinking is a risk factor as well. But we know with smoking, and in the past you've seen people talking with electrolarynxes on commercial. Back years ago, we would try to remove the larynx as much as possible. In the 90s, they had some VA trials where they looked at preservation surgery for advanced larynx cancer, basically seeing that if we didn't take the voice box out and we did radiation and chemotherapy, what would be the long-term outcome. And the studies, there have been multiple different phases of those papers, but they basically said that in advanced, so stage 3 and stage 4 larynx cancer, you can still do radiation and chemotherapy as long as if they don't have a complete resolution, they proceed with laryngectomy, where you take the entire larynx out. And there are new advancements in order to help talk, but you do have a permanent opening through the neck, which is different than a tracheostomy. A tracheostomy is just a hole there that can be closed. A laryngectomy means you take the entire larynx out and you bring the end of the trachea to the neck so that it's a permanent opening. There's no connection through the throat anymore.
So anything you swallow cannot possibly go into the lungs.
But there's different prostheses now that make a little hole, a little puncture from the trachea into the esophagus. And so people learn to talk through that, and they can actually get a voice through that. And so it doesn't condemn people to using an electric voice box.
And one of the advances that I've seen since I've been in practice is a more microsurgery that allows ENT physicians to be able to remove small tumors from the voice box without having to remove the voice box.
So when we talk about small or early stage larynx cancers, so stage 1 or stage 2, a lot of times we can not even use chemotherapy. So the question really becomes, is it radiation or is it surgery? And they have very similar outcomes for early stage. Now, then the question becomes, what has the better functionality? Because if the tumor is in a place that I can't cut out that tumor and then have a good voice outcome, it's better to do radiation. And there are different locations and involvement of that tumor that makes it either a good surgical candidate or not a good surgical candidate. But at that point, because it's so early, we have two options, and our goal is to keep the voice the best as possible.
Yes. And radiation is a high cure rate, but also has consequences. And with radiation, the consequences are delayed. So there's sort of the late effects with radiation. You do affect the voice. If you're like a beautiful a soprano opera and you get radiation, you're not going to have the range of voice or pitch. So it definitely can affect the quality of the voice, especially for someone who is a professional singer or professional speaker. And then obviously one of the late effects is also that ability of the larynx to protect the lungs and the swallowing
and
mechanism.
Sense the ability to close when it needs to, because when we ever swallow and you choke and you cough, 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 and you feel like you're going to pass out because you're coughing so hard, that's your body's protection measure to keep fluids from going into your lungs. And when you don't have that, that's when stuff just goes into your lungs and you get really bad pneumonias, and it's a really bad problem.
Your fellowship was again nasal and sinus. And some of the rare tumors can also affect the base of skull. And you mentioned to me that that's part of your fellowship was getting into that territory as well. Maybe talk a little bit about some of those more unusual tumors that are in that location.
There's a couple types of tumors. Well, there's a lot of different rare tumors, but you can get minor saliva gland tumors in your sinuses. You can get the lining of the sinuses in the nose is called the squamous cell carcinoma, which is what a lot of our types of cancer are. That can happen in the sinuses in the nose as well. Adenocarcinoma, which is a glandular type of cancer that happens in the sinuses as well. You can get esthesioneuroblastoma, which is a cancer of the smell fibers that happen at the base of your skull into the nose. You can get lymphomas of your sinus and your nose, and those we usually do not treat with surgery. Lymphoma in general, you treat with chemotherapy and sometimes radiation, but a lot of times you have to do a biopsy for that. So we have to do surgery to do a biopsy a lot of times. I'm trying to think. There's the important part. There's really rare tumors called like nut midline carcinomas. There's sinonasal undifferentiated carcinomas that are very aggressive. There's a lot of different very rare tumors of the sinuses and the nose. A lot of times people don't notice anything in the nose. And that's, again, the hard part with cancer is that you don't notice it until you do. But the biggest thing to look out for is one-sided nasal obstruction. All of a sudden you can't breathe through your nose. If it's something you just don't want to assume is a sinus infection, because you might delay treatment. And so it's important that we have scopes to look in, that we are a little bit more aggressive in looking up those types of symptoms, or your eye not moving correctly, swelling kind of on the outside of your nose, smell changes. Those are kind of the things that we don't want to see.
So stuffiness that comes every spring or fall in both nostrils, not worrisome for cancer.
Correct.
I mean, it can be inconvenient and bothersome and may require treatment, but a unilateral, only one side nostril, feeling like you can't breathe through one nostril, that's not likely to be just a rhinitis, a hay fever.
Correct. I mean, it could be a sinus infection, but usually that goes away very quickly, and it has green drainage and it has tooth pain, but it's something that doesn't have a lot of symptoms, but you just can't breathe through your nose suddenly. That's something you should probably get checked out.
Since you do have specialty training in the rhinal sinus, what are some of the newer techniques used to treat benign conditions that you would see
Yeah.
based on your subspecialty?
Yes. So we have benign tumors of the nose and the sinuses that we take out all the time. We use endoscopes, so little teeny cameras that go in through the nose. We do most all of our surgery that way, and that's a very key to doing the newer types of surgery, so that you don't have to have incisions on the outside. We used to do incisions on the outside of the nose, under the lip. We try not to do that anymore, and we really
So
don't
you
have
go
to do
through the
that.
nose, and then there's an opening into the
Sinuses
sinus
from the nose.
from the nose.
Yep.
That must be very tiny.
It's tiny.
Do you have to dilate that, make it bigger to get the instrument in, or does you have a small little instrument that fits in there?
I have teeny instruments, and I have teeny instruments that do different things based on the angle that I need, because I can't really change how much space I have, but I can change the angle of my instrument. So I have instruments that go straight. I have instruments that go angled. I have instruments that go up and down. I have instruments that go back. All these different instruments. I have different drills. I have different angles on my scope, so I can see high up into the frontal sinus, or I can see straight. And so it's a lot of equipment.
You actually have a scope that you can go up into the frontal sinuses.
Yep. And I use really angled instruments to go up there. I can drill into the frontal sinus. I can do a lot of things from the nose and not have to do even, 30 years ago, have to drill and go through the front of the forehead this way, or you'd have an incision this way. We can still use those techniques, but we try not to, because those did have complications and morbidity for patients. And so we try to do everything through the nose.
So what would be a common procedure you might do to help someone who has just chronic sinusitis?
Yeah. So basically, if they have chronic sinusitis, we've done all the medicines. I mean, we try medical management first, and they're not getting any better. I use the cameras and little instruments to open their sinuses out and basically clean out whatever's going on. If it's an infection we can't clear, I irrigate and I open up that sinus as wide as possible, and I clean out that pus, and I send cultures, and we try to treat them once we get everything cleaned out. If it's polyps, I have little instruments that are kind of like Pac-Man machines that can up all the polyps or remove all the polyps, and then we get on good treatment after surgery so that we can keep the polyps from coming back. But basically, my job is to open up every little sinus cell, which everyone has their own anatomy. They have their own cells. Everyone has different anatomy, and clean out everything and make it as open as I can so that we can do topical treatments like nasal irrigations or sprays in order to help continue to keep them in a good place.
Okay.
Yeah.
So this is an off-the-wall question. So I was on a above and beyond cancer journey to Nepal with a group of cancer survivors, and this was a breast cancer survivor, but she brought along to Nepal a neti pot.
Yeah, neti pot.
For cleaning out her sinuses. Lots of dust when you're mountain climbing and trekking. Is that a worthwhile procedure for sinus health?
Yes, I every day I'm talking to my patients about using a neti pot.
So describe what that is and how you use it.
So there's different types. There is the old teapot looking thing, what people would stick in their nose and lean over and make it go through one side and the other. The newer ones, there are squeeze bottles, and the reason I like the squeeze bottles because I've never figured out how to use the teapot thing myself. And the squeeze bottle, the whole point is you want to use pressure. You don't want to spray. You want a pressure wash your sinuses. And so you want to use saline. Water isn't great for the nose. And you want to use, there's saline packets or there's recipes on how to make saline or salt. And then you want to use distilled water or boiled water. Do not use tap water. Do not use filtered water. There is bacteria in there that our stomachs can handle, but our sinuses do not like. And there's weird things like amoebas. We don't use tap water. We use distilled water or boiled water. And then you fill up your bottle. I tell people, some people are really good at it. You put the little spigot in your nose and you squeeze and you make it come all the way around and you just pressure wash your nose. Now, I'm not good at it. So
Can you use a water pick?
So the only reason I wouldn't use a water pick is because the water pick has really high pressure and I'm worried it would cause a nosebleed. Yeah. I'm worried it might get you a bad nosebleed. Okay. And so I kind of squeeze, I let it go up and I let it come back out. I just go in the shower or someplace where I don't care if I get dirty, and I do it on both sides. It works well even without sinus surgery, but sinus surgery helps it work better.
Mhm.
And it has been shown, even with COVID, to decrease viral load when you're sick. It decreases bacteria when we culture. And so we know that if you use it consistently, it can help prevent infection, or it can help you get over your infection faster.
I have to admit, in Nepal on the trail, and I'm not sure we used bottled or boiled water, and there may have been amoeba and even leeches in the water. But I was amazed, surprised, and a bit grossed out at
how much stuff came out.
how much stuff came out.
Yeah, there are newer things too, and I don't tell anyone they need to buy them because they're like $100, but it's called the Navage, and it's basically something that sticks one side here and the other side here, and it irrigates through one and sucks out the other, and that tends to help people tolerate the water better so they don't feel like they're waterboarded, but they're $100. They're expensive.
Okay. You know, we have some cancer survivors here, and tonight in our live studio audience, we also have folks that are watching us via live stream, so I'd invite them to ask questions as well. If you're watching us live stream, just put your questions in the comments section, and we're going to turn it over to some questions from the audience now. Poon, hi.
Hello. I do use the neti pot. Well, actually, the squeeze bottle.
Yeah, the squeeze bottle.
Yes, I've used the neti pot and just about every day.
And people that get benefit from it love it. Like, it might seem weird at first, but it helps people. It's helped some of my patients. They have horrible sinus disease and they feel fine on it. And all I care about, if your sinuses aren't, there's nothing dangerous about your sinus disease, which every once in a while that can be something that we got to do because it could cause problems with your eye or into the brain. But in general, sinus disease is quality of life, and it's huge for quality of life. But if people can get benefit from a neti pot, even if their sinuses don't look very great, we do what works for them with the limited mortality. I don't tell them they need surgery. I say, if you're feeling good on what we do, that's all that matters. And when you're not, at some point, then surgery can be helpful.
So how many times a day can you use it? Because I just do it in the evenings.
So I have people, especially if they have chronic sinus disease, do it twice a day. I do have people that do it more frequently. And as long as it's not causing things like nosebleeds and you're using, not filtered water, but distilled water and not, tap water, and you're using a recipe that's like bicarbonate and salt, I honestly, you could use it as many times as you wanted to. Now, I think at some point, if you were doing it like 5 or 6 times a day, you might have some irritation in your nose, and then that might cause dry crusting in the nose. But in general, even saline is humidifying to the nose. And I have people on just saline sprays that can't tolerate the rinses. And I tell them to use it, just carry it around and squirt it in their nose constantly because it humidifies the nose and the nose really likes it. So I think 2 times a day is really good if you can remember to do that. I'd be bad. I tell people I'd be a horrible sinus patient because I would be bad at doing it twice a day. But when you're that miserable, you remember to do that twice a day.
So if you use Flonase also, would you use the Flonase after is what I've been doing?
Yes, that is perfect. I tell everyone to rinse their nose, get it all to drain out because sometimes it drains out a little bit later, and then spray your Flonase because we want the Flonase to stay there. And Flonase is great. It's healthy. It's over the counter. It treats more than allergies. It treats chronic sinus disease. It treats congestion. It treats infections. There's been studies that if you have a sinus infection, that if you use Flonase, you feel better. And they did that with a placebo. So people were spraying other stuff and they didn't feel as well. And so, yes, it's exactly correct. You want to rinse your nose and then spray your sprays.
Any risk that using Flonase makes you need it more, that you become, addicted. I'm going to say the word addicted.
Yeah.
I don't.
No. So the thing that you have to remember is that there is one spray that's bad for your nose. There's one spray that is addicted, and that's called Afrin. Oxymetazoline is a generic name, and phenylephrine is another type. Those are bad sprays. They are good for certain things. They're good for nosebleeds. They're good for if you have a cold. But you don't want to be on them more than 3 days because they are addicting to your nose. And so that carries over into people thinking other sprays are bad to be on long term. And the key is that Flonase, and I have people on Flonase long term every day for years and years, is safe. If people have a side effect from Flonase, it's because the spray itself, because it's kind of shoots out in a very direction, it can cause kind of irritation on their septum and it can cause nosebleeds. There's some rumors about thinning of the nose, just because we know that chronic steroid use on the skin can thin the skin. But in general, I don't see that. And there isn't any studies to support that. So as long as you're using the spray, and I tell people to aim it towards their eye on both sides, and they're not having any irritation on their septum, they can be on it long term, and it really helps people feel better long term.
Okay, great.
Another question.
Yeah.
What causes sinus cancer?
So we don't always know. We know that being around chronic irritation, so chronic irritants or chemicals, can increase the risk, just like it can in the lungs as well. It's the respiratory cells, just like the lungs. Smoking can increase the risk of sinus cancer as well. But in general, it tends to be rarer, and it tends to be things that we can't predict. Because they're rare enough, we can't always find associations. And so it honestly tends to be bad luck, is what I tell people, is that we haven't found. It depends on what different type of cancer, but in general, if it's not smoke or chronic irritation, plastics, wood, that type of thing has had some correlation with sinus and nasal cancers. If it's not that, it's usually the people that I've seen has just been spontaneous, where they didn't do anything wrong. It was just a cell that got out of hand, and their immune system didn't do a good job of keeping it in check.
Great. Angelina.
Yeah, to kind of tether on that first question, because I'm a type that gets allergies all the time, and I do Flonase. But how about this, the saline solutions that come in the bottles themselves? Are those okay?
Yeah, those are great.
Effective? Okay.
Yeah, those are great. So the reason why a rinse might be a little bit more effective than the spray is because what it's doing for allergies particularly is it's taking all the allergens from the nose and flushing them out. A spray does an okay job. Like, it's probably not getting in as far as a rinse. It's because it's all about pressure. It's all about seeing whatever you're spraying in come out. So I think of sprays as being, if they help you, great. But if you're not having as much benefit, I think a rinse could be a little bit better, because you want to rinse out all those particles you can't even see, and you want to see that fluid coming out. So you want to have fluid coming in and fluid coming out. And that usually will have the allergens in them. And then you can hopefully have less symptoms, because you're kind of cleaning out the allergens that are caught in your nose.
Yeah, but what about pills like Claritin?
Yep. And I love Claritin. I love Zyrtec and Allegra and Zysol. And I use those too. And those can help with nasal symptoms, and they can help a lot with like sneezing and itchy water eyes, scratching your throat, having that really, really irritating throat scratch. And I think there's a combination of using all of these. Sometimes you need, and sometimes if you're not having a lot of nasal symptoms, all you need is Claritin. If you're having a lot of nasal symptoms and Claritin isn't controlling it, then that's when we add rinses, and there's multiple sprays. There's Flonase, and there's an allergy spray called Astapor or Astelin spray.
Oh, okay.
Great.
Thank you.
Yeah.
We have a question over here next, and then we'll come back over here. Kevin, do you have a question?
Okay. Now, if you suspect there's a problem, and how do you know if you don't need to go to a GI specialist versus an ENT?
That can be hard. I find that for GI, obviously, if you're having blood in your stool, if you're having nausea, vomiting, and those symptoms, probably GI. If you are having throat symptoms, or kind of even in the throat, even if it is GI, we kind of have easier tools to kind of, if you can get into us pretty quickly, that we can do a scope and make sure that it's nothing above the esophagus. And then sometimes, and a lot of times, I do send people to a gastroenterologist because I don't see anything, and they do need an upper scope. But that requires anesthesia and going to sleep. And so sometimes people do see me first, and that's okay, because I can scope you in the clinic with very little discomfort, and we can kind of know right away.
And you're talking about symptoms of reflux, or what
reflux, or something stuck in your throat, problems swallowing, like things get stuck, hoarseness, postnasal drainage. I mean, those sore throat, that type of thing.
And then would a GI send somebody to you then?
They sometimes do. Yeah. I mean, sometimes, not as commonly. Usually I think I send a lot of people to GI, but I think they would send something if they were doing a scope exam and they didn't see any acid reflux and they were complaining of chronic cough or throat irritation, sometimes they're like, it's not us, go to see the ENT. Sometimes when they're doing a scope under anesthesia, they might see something because they have to go through the mouth to the esophagus. Sometimes every once in a while they'll see something, they don't quite know what it is, so they'll send you my way because they saw something they didn't quite know if it was normal or abnormal.
Okay.
Yeah.
Yeah, I have a question, a couple of questions. With tonsils.
Yeah.
Is it better to actually have your tonsils removed when you're young, maybe to prevent some of these cancers?
That's a good question. So we went through a couple waves of tonsillectomy. So back probably in 50s and 60s, everyone had their tonsils out. And then we said, hey, there's complications from tonsillectomy, and I'll talk about that. We should not take people's tonsils out. And now we actually have guidelines. Ear, nose, and throat doctors have guidelines that we should follow that tell us when it's appropriate to offer surgery. And the reason is because tonsillectomy is not going to cure all throat cancers, because there's tonsils behind your tongue called the lingual tonsils. And I don't know the actual numbers on it, but they might be the ones that hide cancers even more frequently than the tonsils. And you don't want to remove those because it's a hard surgery and it causes swallowing problems. You can, and sometimes you do, but that's pretty rare. But there's bleeding with tonsillectomy, and the bleeding isn't during surgery. It's for 14 days after surgery, and it's significant. It's an artery, it's spitting up blood, and in some cases has been life-threatening. And so knowing that there can be complications, we don't generally take tonsils out unless they're causing a problem. So in kids these days, we do it for recurrent infections, but it's actually quite a high number. It has to be 7 infections in a year. Doesn't have to be strep. It can be any significant episode of tonsillitis. It can be 5 in 2 years or 3 in 3 consecutive years. But the more common reason we take it out in kids these days is because of sleep apnea. And we found that kids actually get sleep apnea from large tonsils and adenoids. And we know that they don't do well in school when they're not sleeping well overnight, and they have hyperactivity and they don't concentrate very well. And so if kids have really large tonsils and they have symptoms of sleep apnea, a lot of times we do take tonsils and adenoids out for that. But for prevention of HPV-related cancer, we aren't right now. The biggest thing we're trying to recommend is actually the vaccine, because even though we don't have long-term data on it yet, that our thought is that if you can have a vaccination when you're a child before you have an infection, that you can try to help your immune system fight off that infection and long-term prevent the risk of oropharyngeal cancers.
Yeah. I also have a question. You talk about the path that going up through the nose with the camera. I've had quite a few of those myself. But one of the problems I've had was polyps, nasal polyps, and a year or so ago I had about 10 polyps removed. Is there the possibility of those polyps becoming cancerous after some time?
No, not usually. Usually polyps by definition it's a word we give to benign disease, so non-cancerous disease. Every time I go in, I take polyps out, I send it for pathology to make sure. But I don't know of those actually causing a risk for cancer. Polyps do come back, and they have a high risk of coming back, like 60% come back. And so it tends to be a chronic disease that either you need repeated surgery on, rinses help, and I put steroid in the rinse to prevent them from coming back. And there's newer treatments, immunotherapy, such as Dupixent, and there are different immune modulators that help to prevent polyp recurrence. And so those are the kind of the newer treatments for nasal polyps to prevent needing to have surgery so many times.
Is there kind of like people that get nasal polyps, is it kind of genetic that
Yes.
most people get?
Yes. So polyps, sinus polyps in the nose are very similar to asthma in the lungs. And so it's a high risk of genetic component. We know that people that have asthma, did I say asthma? Asthma in the lungs. Yeah. Asthma, that if you have parents that have asthma, that you have high risk that the kids might have asthma. And it's the exact same pathology. Not for most of the people, there's different variants, but for most times when we think about nasal polyps, it's run by eosinophils. It's the same process in the sinuses as it is in the lungs. And a lot of times people have asthma and polyps. But yes, if someone has nasal polyps, they're higher risk of their family members to have it as well.
We have another question over here.
Hi. questions from viewers, doctors.
Okay.
The first one is, if someone has many sinus infections that require antibiotics, but they also had surgery years ago because of a deviated septum, should nasal wash be done regularly?
Yes. So in general, when I do sinus surgery for infections, I usually tell people I can't totally prevent infections, but the reason to do sinus surgery is to open the sinuses up and allow us to better treat them with washes, medicines like Flonase, and sometimes even allowing me to culture you in clinic so that I can direct antibiotic therapy. Deviated septum is more for breathing, but it also can help with the rinses getting in better. So yeah, I think rinses sound like a good option. And sometimes if they continue to have infections, seeing an ENT, even if they're doing all of this, because sometimes you can get scar tissue and you might need revision surgery sometimes.
The other question is about the rinses that you just spoke of. Is there a recipe for that?
There is a recipe. If you Google it, there are a lot of recipes, but I don't have it off the top of my head. I have it printed out in clinic. But usually you want to use canning salt and you want to use baking soda. The baking soda helps to decrease the burning sensation, and then you want a certain ratio in your water. There are pre-made packets that I'm a fan of just because I'm a little bit lazier, and they have that right ratio, and you can buy them over the counter, even individually, and then they're pre-ratioed for a rinse bottle.
What are they called?
Oh, there's different kinds. Like if you go to the pharmacy aisle, there's like a whole row of them. There's Neomed is one of them. There's
and they're labeled as sinus rinses.
There's sinus rinse bottles or a Neomed. Yeah, I think a Neomed rinse bottle, and then you'll have the packets that are I think they're just called refillable salt packets or something like that.
Okay.
Yeah. But I know Neomed is Neilmed, is a brand that I give out in clinic just because they give me some samples, but there's other types there too. Yeah.
Okay, great.
And last question, you talked about the huge risk smoking is, obviously, with all cancers, but particularly in your discipline. Is there a safe time? Former smokers, they're always wondering, did I stop smoking soon enough?
Yeah. You'll always carry some risk. Even if you've quit, you've just decreased your risk substantially. But even if you've had a substantial smoking risk, meaning that it's more than a year, you are always at some risk for cancer. But you've done a great thing if you've stopped smoking, and you've definitely decreased your risk. It's harder for me. I don't know if you have insight on the percentages that you've decreased.
Yeah, I would say that the generally accepted is that once you get to 15 years of not smoking, you approach the risk of a non-smoker. I would agree with you. Good. And that has played into the lung cancer screening guidelines. So we talked about cancers that you screen for. That's people who don't have symptoms of a cancer but might be at high risk. So we obviously cervix cancer, breast cancer, colon cancer, prostate cancer, but lung cancer screening is also done. But it's only done on individuals who have a history of smoking, and they either are current smokers or have quit less than 15 years ago. Yeah. So that's kind of where the science on how long you have to go without smoking before you're not considered in the high risk category.
That's good to know. I actually didn't know that. So when I see people in clinic, I definitely think the longer you've gone out, the better I feel. But anytime, and I always try to ask about smoking history, anyone that has been a smoker, I do kind of look a little harder, even if you're out longer than 15 years, just to make sure that I'm not missing something.
Yeah. Well, great. The hour just flew by, and wow, you are just a delightful person to interview, a wonderful physician that I look forward to collaborating with more.
Me too.
I already have a couple patients that I want to talk to you about.
Oh, awesome.
After we finish our program. But this has been great. We'll definitely have you back again.
Good.
And if any of you watching know someone that would benefit by watching this program or listening to it, it will be available as either an audio or video podcast on the Above and Beyond Cancer YouTube channel or the MercyOne Cancer Center website. And I hope you'll all join us again next week. Thanks for being here tonight. Thank you.
Thank you.